research methodology, may I invite the core faculty, Dr. Nipun Verma, Dr. Vishal Sharma, Dr. Usha Datta, and Dr. Rakesh Agarwal. May I invite Dr. Nipun Verma?
On behalf of organizing committee and my co-chairs and dear audience, I would like to welcome you all for research methodology workshop. I am going to speak in next 10 minutes on formulating a robust study question, and I bring greetings from PGI Chandigarh. So why does study question matters? It's important not only because it drives the research, but it also gives meaningful outcomes that can change the field, that can move the outcomes and the policies. It not only informs the study design, but also the methods and interpretation. It's crucial for evidence synthesis and decision making. And last, which we derive from studies, are the systematic reviews, guidelines, and policies which are invariably dependent upon the robust study question. So, in a natural history of any study, there is a starting point or an inception point which starts with a good question. Then it goes to hypothesis, study design, data collection, analysis, and then dissemination of results and incorporation into policy decisions. So when we start with a research question, it is often starting with a hunch. In general, we think that sometimes we see a phenomena in real world and we try to ask ourselves, why is that phenomena? What is that phenomena? How it is going to impact the outcomes of a given individual, and can we modify that phenomena? So let me give you two examples which offhand came to my mind. That patients who are presenting to us in ER, which of these patients with ascites are likely to have cirrhosis, and why some patients with cirrhosis die in next 30 days. So this is just a question from hunch. Now think, all of you, please think your own question, and we'll come to the end by formulating a robust question through robust methodology and manuscript throughout this research methodology workshop. So what are the attributes of good research question? It is defined by an acronym of FINER, which stands by the feasibility, interesting question, being a novelty in the question being asked, ethical to perform, and it should be relevant not only to physicians, patients, but also to the policymakers, ultimately to drive the field. And it is often clear, focused, answerable, and relevant to stakeholders. So FINER is, I want to revise, it should be feasible, interesting, novel, ethical, and relevant. So coming back to our original questions, how many of you people, the audience sitting here, think that this question is robust? Raise your hands. Which cirrhosis patients presenting with ascites are likely to have SBP? Is it a good research question? How many of you think it is not a good research question? Raise hands. So let me give you an example why this is not a good research question. So a research question is based on a framework of PICO, where what does PICO means? We all understand PICO is population, intervention for intervention studies, exposure for observational studies, or index test in a diagnostic study. Comparator means then a comparator population, which can be anything, a second intervention, placebo, or standard medical therapy. In exposure, it could be non-exposed individuals, and in diagnostic test it can be a reference test or another index test 2 in comparison. And then we look at the outcomes in any research question. Then there are several derivatives of this research question, which also includes the time and exposure, and other acronyms are also given, such as SPICE. But great guidelines recommend that timing and exposure is already included in the PICO framework, and where we look at, in the outcome itself, they have defined that we are going to look at a particular outcome or an endpoint in a given time frame. So there are different sorts of questions. It can range from epidemiological questions to pathogenetic questions to diagnostic, interventional, or prognostic questions. A typical epidemiological question would be, what is the prevalence of hepatic encephalopathy in patients with decompensated cirrhosis? For pathogenesis, there could be a question such as does elevation of IL-6 levels predict acute decompensation in cirrhosis? In a diagnostic example, there could be a question such as how accurate is ascitic fluid calprotectin in diagnosing SBP? In an intervention, it could be, does any albumin infusion reduces the mortality in cirrhotic patients with sepsis? And in prognosis, there can be a question that, can AI-based clinical models predict 30-day mortality? So coming back to our original two questions which we posed, uh, which cirrhotic patients are likely to presenting with ascites are likely to have SBP? So here the P is patients presenting to ER with ascites. Here the exposure or is not clear. I have not given which patients, what attributes of a patients with cirrhosis with ascites exposed to a particular risk factor are likely to have SBP. So there is no clarity on exposure in the comparator population in this question. Likewise, in the second question, why some patients with cirrhosis die in 30 days? Again, here the P is patients with cirrhosis, exposure is not clear, and outcome, although it is clear, it is mortality in 30 days. So let us refine our question number one. So our original question in front of you, the refined question would look like, in a cirrhotic patients presenting to us with ascites, how accurately does a high calprotectin in the ascitic fluid compared to a low calprotectin in the ascitic fluid detect the presence of SBP? So I think it is very clear from this question that the population here is cirrhosis patients with ascites. The exposed population is high calprotectin in ascitic fluid. Comparator is low calprotectin, and occurrence or the outcome is presence of SBP, which can be operationalized with the definition of ANC values above 250 in ascitic fluid. And according to the final criteria, it seems to be feasible, especially in the labs where calprotectin is available. It is interesting because it is a novel biomarker. It is ethical to perform because SBP has a very high mortality, and there is an unmet need for diagnosing SBP early on, and it is relevant not only for physicians, patients, but also for the healthcare system overall, because treating SBP early on would reduce mortality and improve the expectedly improve the quality of life of patients. Let us refine our question number two, which was why some patients with cirrhosis die in 30 days. The refined question would look like, among patients with cirrhosis, which clinical or laboratory factors specifically given in a study design are associated with 30-day mortality? So here the refined question, the PICO format would look like, patients with cirrhosis exposed to a particular clinical or lab variables such as hepatic encephalopathy or higher MELD score compared to absence of these features, and the outcome is 30-day mortality. And again here it is feasible, interesting, novel, ethical as well as relevant, because in field of cirrhosis a short-term mortality is relevant not only for the patients but also for the policymakers. Let us take an interventional question, which we all understand. Let's say I ask a question in patients with acute and chronic liver failure at high risk of mortality. Does high volume plasma exchange compared to standard volume plasma exchange reduces the 30-day mortality? And here again, PICO format, you can see that patient population here is patients with ACLF at high risk of mortality, let's say MELD score above 15, who are exposed to, the intervention here is high volume plasma exchange, and comparison here is standard volume plasma exchange, and we are looking at 30-day all cause mortality. Again here it is feasible, interesting, novel, and ethical, and it is relevant, very relevant to improve the outcomes of patients with such therapies. The common pitfalls in poor study questions are that some of the times it is very broad, as the examples which I gave, without any exposure and comparator population. Sometimes it is very ambiguous when the outcomes are not clearly defined, and sometimes there are unrealistic comparator or time frame. In a given time frame, if a study question is not being answered, then not feasible, then it is a poor research question. So, typical examples of poor research questions include what are the outcomes in cirrhosis, and it could be very narrow sometimes, that does 5 grams of IV albumin given within 30 minutes of paracentesis in non-alcoholic cirrhotics with high SAG can reduce 12-hour creatinine rise. So, if the research question is very, very narrow, then it is again losing its external validity. And is early treatment better in cirrhosis? These are the kind of vague and the ambiguous questions which are poor research questions. So refining the research question, as I said, based on finer criteria, but also it should be based on a thorough review of existing evidence, engaging the domain experts and the senior people and the major stakeholders, not only doctors, would I would say the patient and patient representatives, in formulating that question, because what matters to us may not matter as that much to the patient. So there has to be an engagement of several stakeholders in defining a robust study question, and we can always have discussions before formulating a question. And there can be different forms of questions, simple and to complex. And as I mentioned in the initial slides, that the intervention or a comparator population can be a combination of the interventions or a sequential interventions, as we can see in this slide. Further refining the questions can be, guided by a rating scale on a formal assessments, and this type of exercise is often done in defining the research questions for systematic reviews, because that forms the basis of all the literature review. And for give you an example of ACLF patients with treated with plasma exchange, the question which I mentioned for intervention, the population there was ACLF at high risk, high volume compared to standard volume, and looking at the outcomes. We can look at the outcomes on a rating scale of 1 to 9, from least importance to most importance. And again, here the importance of stakeholders in rating those the outcomes, and the outcomes can range from primary to secondary, which we all do in randomized control trials. So which one to keep as a primary outcome should be the one which is critical for decision making. And most of the patients with ACLF, and here we see short term mortality is the most important outcome for the patients, for the doctors, and also for the policymakers. And rest of the like say for example the complications such as TRALI or TACO is again a critical outcome, and it can also be rated as a high number in refining the outcomes. Whereas the outcomes such as nausea or vomiting because of any intervention can be rated as low importance. Finally, we will go in the subsequent part of the workshop how the research questions will be linked to the study design and to the protocol, and to minimize the bias. And there are several resources, tools, and AI tools also. Grade GPT is something which is developed by Cochrane collaboration, which is called Grade GPT, and it is freely available. And anything about research methodology, you can question and answer in a chatbot manner. And take home messages for this presentation would include that study question is your compass, and use PICO for your structure, finer as an acronym to be useful, and align with grade for impact, so that we minimize the bias in our study design by asking our good research question, and that should help to decision making and policy decisions. Thank you very much. I would like to call Dr. Vishal for the next presentation.
First of all, I'd like to thank the organizers for this opportunity. Uh, First of all, I'm not a methodologist, so my knowledge about study designs is superficial. I'm lucky that we have experts like Professor Usha Datta and Professor Rakesh Agarwal here. So if I make a mistake, I request them to correct me so that there are no wrong messages which go. So I think once you have decided that you want to answer a particular question, then you need to find the right way to go about it. सत्य एक है, उसको पाने के तरीके बहुत हो सकते हैं, but which is the way which suits us, given the resources, given the funds that we have, given the time that we have, that is what we are going to kind of address. So the problem is that the truth actually is for the entire population. You know, I would want to know what is the, let's say, prevalence of IBD in India. So then ideally, I would want, you know, the census is going to happen. I would request the census organization, you know, Home Ministry and all, to put one question that how many of you have a bleeding per rectum? You know, and then the entire country answers that, and I should have the resources to, you know, then do a fecal calprotectin, and then resources to look at individuals who have fecal calprotectin high and do a sigmoidoscopy and see how many have ulcerative colitis. But that obviously is not feasible. You would have a census in 10 years. Anyway, the number of questions are limited. And you really don't want to, you know, you don't have those kind of resources to handle that kind. So what you do is you select a sample which is kind of representative. And then out of this population, and this sample should be similar to population, you make some estimates, and then you say, okay, this is the truth for probably the entire population. And then you probably will select some areas, maybe some rural areas, some urban areas, and maybe try to find the answer to that question. And then there are various study designs, and this is what I am supposed to do, to talk about these study designs. Some of the studies are purely descriptive studies. They would not have a lot of analysis. They just kind of find out what's happening broadly. Maybe identify a problem, but not, maybe also quantify the problem, but not really look at associations or, you know, do a lot of analysis. And then, of course, you have analytic study designs. Mostly what we have is observational. You just see what's happening. And then you have what is experimental or interventional design, where you actually intervene. So these are the broad study designs that are available to us. Now, what are we looking at? Broadly, what we are looking at is exposures or intervention. So when something is happening naturally, that is an exposure. But when we are doing something, that is an intervention. And that obviously is an independent variable. And then we look at what change that exposure or intervention makes to the outcomes that we are interested in measuring, or which may be relevant in respect to that. So broadly, what are the, you know, different types of designs that we think about when we decide about a study design? One is interventional versus you know, observational. So certainly, if you want to see whether smoking causes, you know, this is a typical example that is given, smoking causes lung cancer. You're not going to randomize people to smoking and no smoking. That would be unethical, obviously. So, because today I think we know that, you know, smoking is harmful. So obviously what you will do is probably an observational design. So you can't intervene in such a setting. Then what you have is a cross-sectional versus longitudinal. So you have limited resources. You can just look at a particular thing once. That's cross-sectional. So the resident sitting here, can we find incidence using a cross-sectional study? Can we find the prevalence? Yeah. So then, of course, we have talked about descriptive and analytical. And then what is important in deciding what kind of observational studies we are doing is the directionality. Whether we are first looking at exposure or the risk factors and then following them up to the outcome. But there's another way that you know the outcome, okay, this patient had gastric cancer, and then you go back and look at the risk factors. So these are, the directionality of exposure. And of course, prospective versus retrospective, where the outcome has already happened, that's probably retrospective. And if it is yet to happen, then it is a prospective study. So which design to choose is basically dependent on the nature of your study question, the goal of your research, and the resources. And more often than not, it is the resources which decide the study question. So we'll go to each of the study designs and talk very briefly about each of these. So let's say there is a descriptive, what is a descriptive cross-sectional study? So let's say in all patients with gastric cancer, you measure H. pylori. So you could use a serology, or at the time of biopsy, you can take a biopsy. So it will provide a prevalence of H. pylori in gastric cancer. But let's say, there are any additional factors which are, you will just say this is the prevalence. You will not be able to say whether that is causing, or whether that is equal to the general population, or it's at a higher risk, right? So that's what a descriptive cross-sectional study will give you. Then there are studies which are not done at an individual level. Let's say that we have blood bank, blood banks, across the country there are blood banks. So you can take, serum from them and look at H. pylori positivity across blood banks. And then you can say, okay, we have some registry data of gastric cancer, and now this is the H. pylori serology. So the states which have a high H. pylori serology, they have a high gastric cancer. Now, these are ecological studies. And the problem is that they may not be true for the individual. There would be individuals with gastric cancer who would probably, may not have H. pylori, but broadly it will give a trend. And then, of course, there could be, different things which may confound. For example, let's say there are, very high crowding is there, and that's causing H. pylori, and then there is another risk factor which this crowding causes and results in maybe gastric cancer or something. So there would be confounders which you would probably not be able to address. And then, of course, you can't really, in India, for example, there's a lot of migration which is happening. So you can't account for that. So there would obviously be problems with an ecological study, but this is one of the quantitative design, the descriptive designs. The other is quantitative studies, which we very infrequently use, which basically is to obtain certain cultural information about values, opinions, behaviors. So it's not, we are not saying how many, we are just saying what's happening. What do you feel? Something like that. And of course, the methods or tools are very, very different from the standard studies that we use. Sometimes it's just observation of what people are doing. For example, I'm sitting here, so some are sleeping, some are, listening, others are looking at the mobile phone. So I'm just observing without intervening. And then maybe I'll just say that, okay, these are the behaviors in a boring class about, or a lecture about study design. The other is in-depth interviews. And that is, that's a very formal kind of a way. You record the interviews, you make a entire summary of the interviews, and you take out ideas or, concepts out of that. And then, of course, focus group discussions. But these are not quantitative designs. And these studies are not very frequently used, but they are very important studies, especially let's say you're trying to create a questionnaire about quality of life or something. So they will give you the initial ideas on what domains you really want to address through those questionnaires. So now we come to the quantitative or analytical designs, where one of the most important designs is a cohort study. So cohort came from a term from a Roman army, which has a unit of 480 men. So they are men, who have some character in common. They were all, in the Roman army. So cohort is a group of people who share a particular characteristic. And traditionally, cohort studies are prospective studies. So obviously, you have a cohort of people who are free of disease at the start, and you may estimate exposure at the start. For example, let's say you have collected the blood samples, and you look at the serology for H. pylori, or maybe you collect the stools and look at H. pylori. And then let's say you don't initially, right now we know that probably H. pylori is a causative agent. Let's say we don't know that it's a causative agent for gastric cancer. And you follow them over a decade or a period of time, and then you say how many in the positive versus those who did not have H. pylori developed gastric cancer. So this is basically a cohort study. So you have the entire group of individuals who were at risk, and you were aware of the exposure at the start, and then you follow them up over what's happening over a period of time. So there is also some what people call as a retrospective cohort. For example, you already have a cohort which is established for, let's say, H. pylori and gastric cancer. But then it is also possible down the line, a decade later, that okay, now I want to know whether H. pylori causes pancreatic cancer. So you can look at the same cohort and find out the individuals who developed pancreatic cancer, and you already have the exposure. But the important thing is that this was not your initial the study question for which the cohort was designed. So that is why you will see that when a cohort is established, a large number of things will come out of it. It's not just the initial 5 things which were thought about. So what are the pros or benefits of doing a cohort study? That you can, to some extent, establish causation. And one of the important things about, we will talk maybe about Bradhill criteria, is the temporality. That the exposure has preceded the outcome. It can assess multiple outcomes and even multiple exposures. But the problem is it is very time consuming for most of the questions that we want to answer. It is costly. There would be a loss to follow up. I mean, it's never perfect that everybody you initially included you would have for the final evaluation. And some of the confounders may not be accounted for. You were looking for H. pylori, and let's say you make a question that okay, H. pylori is also responsible for pulmonary TB, whereas the confounder is the overcrowding, which may also increase the risk for H. pylori and pulmonary TB. So you will get a false statistical relation between the two. And unless you are aware of all the confounders and take into account them at the start, obviously you may miss them. So these are some of the problems with a prospective cohort. The other design is where you go the other way, case control. So here, especially let's say there is a disease which is not as frequent, and it doesn't make sense to follow up a large cohort for development of that disease. So what is probably better is that you look at that disease and you take some controls who do not have that disease. And the best way usually is to match them for age and gender at least, and some of the other things which you may want to match, except probably the exposure that you're looking for. And then see whether that risk factor was there more frequently in cases as compared to the controls. So here you go from, okay, I think I will have to hurry up. So you go from outcome which is already developed to the risk factors. The important thing is to really choose your controls properly. Let's say for the same question, that gastric cancer and H. pylori, I choose peptic ulcer disease as controls. Now that will be problematic, because obviously you may have more H. pylori in peptic ulcer disease than probably even in gastric cancer, or maybe similar, and then you will say, okay, so the very important thing in these kind of designs is to choose the controls properly. It is cheap, doesn't consume a lot of resources, very useful for rare diseases, but you don't have a temporal association. There may be a selection bias because controls may come from a different background, may not be relevant. Confounders may remain unaddressed, and there is a very important recall bias. That individuals who develop a disease are more likely to recall exposure to a particular thing, and they will probably blame that, okay, this was the reason that I got this disease. So there is all the question of recall bias, and you will never know the risk because you never had the entire population at risk. What you will calculate are the odds, and I think that will be discussed subsequently. So within these studies, you can do, for example, in a cohort, there is a large cohort, you can actually do a case control. That's a nested case control. You select cases, and then out of the entire cohort, you can take the matched controls. So now coming, as you can see that observational designs have their biases. The problem is that you cannot address all the confounders because you may not even be aware that a particular thing is a confounder. So the best way probably is, an interventional study, especially when you are looking at, a particular therapy. And this largely will take care of most of if it's done well, the allocation, concealment, and blinding are kind of done well, probably it will take care of most of the confounders. And that is why they rank the highest as far as the, the importance is concerned and causation is concerned. So for example, we can take individuals, all individuals with dyspepsia, and we can see whether they will develop gastric cancer or not, and whether H. pylori therapy will prevent it. So you can take all with functional dyspepsia, look for H. pylori, randomize them, and this obviously is unethical for the knowledge that we have. But let's say we don't know H. pylori causes gastric cancer or not, and then you could potentially randomize them to screening and therapy versus not doing that. But obviously, we know that this is unethical, so there could be other designs. For example, cluster randomization. You don't have many resources, you can do it in one of the regions, some of the villages you can pick up, screen them and treat them. And others you may not do, so that's a cluster randomization. Crossovers are usually used in other situations where you can have a quick washover. For example, let's say some drugs which have a shorter duration of action, and then you can, for the same individuals, the other therapy can be used. And then there is a factorial design where you can use multiple interventions in a same design, like 2 therapies or a combination of 2 therapies, which is the classical 2 into 2 design. There are a lot of other variations in randomized trials. I think I'll skip that for the lack of time. And also some non-randomized control trials, which I think I'm going to skip. But the last thing I'm going to talk about is a diagnostic test accuracy. And the one example I'm taking is that is gastric biopsy better than stool antigen for, let's say, diagnosis of H. pylori. And you can do this in patients with dyspepsia, but you will have to have a gold standard. You may use a PCR, or you may use any test positivity as a gold standard, and then you say how many were true positives, false positives, or whatever for your test, and then you calculate the sensitivity, specificity, PPV, and NPV. So this is the summary, and I think I'll not go over this because I've already talked about this, but I'll leave you with this slide. Thank you. I'll now request Madam to take the next one.
Good morning, everybody. So, approach to statistical tests requires a good understanding of research methodology. We have 15 minutes, so I have made it as simple as possible, and so that you can get a flavor of what has to be done and how we do these things. So, approach to statistical test, a practical guide for clinicians. You have a large population. Suppose I want to study a new drug in diabetics. I cannot include all the diabetics in the population. It is just not practically possible. So even in a thesis, we will find that we can include only a small sample. So we draw a small representative random sample, which is adequate. So what is adequate? We do sample size calculation and choose our adequate sample. And this is the small n we are going to see. Even if your small n is 10,000, it will still be the small n because it is a sample of the whole population. And here, this small n, we closely observe and analyze. And in this, we give the descriptive data of our population. This is the mean, this is the standard deviation, this is the median, this is the IQR, these are the counts. So this is how we describe our primary data. That is called descriptive statistics. Now this we extrapolate to, from whatever your study, you have done a study in say 50 patients, 100 patients, 2,000 patients. From this you want to extrapolate and tell everybody that this drug works in diabetes. So you want to tell the whole world that it's going to work, so that somebody sitting in Bahamas can also use the same drug. So you want to send it as a message to the whole population. Now, how can you send a message of what you have done in 100 patients to the whole population? That is when we use inferential statistics. That is when, with what confidence can you predict that whatever you have seen or whatever you are interpreting, you can interpret it for the larger population. So that is why the confidence intervals are usually wide in small studies. Larger the sample size, the confidence interval narrows. So there are set principles and procedures to analyze data, and that is where we use probability theorems, and that is where is the inferential statistics there. So I'll take a very simple study design to study the association between obesity and triglyceride. Okay, all of us as clinicians know that with obesity there could be increased triglycerides. And then is there a relationship between triglycerides and cholesterol? We know that increasing triglyceride may be associated with increasing cholesterol. And does drug A result in more reduction in triglyceride compared to drug B? So I've taken a very simple example. Now, the clinical scenario is this, that our study question is obesity associated with increased triglyceride? So now we convert it to a statistical component, that is our hypothesis is obesity is associated with increased triglyceride. The null hypothesis is always quoted as the conservative approach. So there is no relationship between obesity and triglycerides. So we start from this null point. This is how the statisticians start. And then we say that the alternate hypothesis is obesity may be associated with higher triglyceride or lower triglyceride. So that is why we use two-sided test. Okay. So this is a simple study design. There are 100 obese patients, 100 overweight patients, and 100 normal people. We look at their baseline, their weight, triglyceride, cholesterol, fatty liver on ultrasound. Then we give drug A versus drug B, do an RCT, and then reassess at 4 weeks or 8 weeks or 8 months, whatever we want to call it as a time frame of the disease. We reassess the same parameters after this. So it's just a simple study design. This is our baseline data. This is fictitious data, but just to drive the point that obese people, we got some weight, overweight people, we got some weight, controls, we got some weight. And similarly for triglyceride, cholesterol, fatty liver, and grade of fatty liver. Out of this, can anyone tell me which one is likely to be normally distributed in terms of the weights, in terms of the triglyceride? Just a guess, which one is normal, which one is not normal? Yeah, louder please. Obese weight is normally distributed or skewed? So a rough guide is, you look at the standard deviations. Very wide, you know that it is likely to be skewed distribution. Obesity, obviously 100 plus minus 10, more likely to be normal. So we have a statistical test to look for them, but just eyeballing the data tells us. And then this is the post-treatment, we get some values. Again, what happened to the weight, what happened to the triglyceride, you did an ultrasound for fatty liver, you also graded it, so you got some values. So there are only 5 questions which you have to ask yourself to decide which test to apply. The first question is, what is the type of variable you want to test? Second is, what is the data size? Is there less than 30 patients, more than 30 patients? Is it normally distributed? Are the continuous variables normally distributed or skewed distribution? Is it one group, 2 groups, or 3 groups? And are the samples related or unrelated? Just these 5 questions we have to ask ourselves. So first is, what is a variable? What is the variable? The nature of the variable. So nature of the variable can be a category or can be numerical. Okay, it can be either male, female, it can be obese, non-obese, high triglyceride, low triglyceride. So these are 2 categories. So they're mutually exclusive 2 categories. You remember the Venn diagrams we used to draw in maths? 2 Venn diagrams not intersecting, mutually exclusive. So it is yes, no binary, more than 2 polynomial, and more than 2 with an order is ordinal. So let us look at a very simple example, and numerical is continuous or discrete. So I'll come to these 5 points with simple examples. Obesity, yes, no, it's a binary, yes or no. Okay, so you can see either a person is in the red rounds or the green circles. Next is polynomial. City of residence, is he coming from Ambala, or he's coming from Chandigarh, or he's coming from Pathankot? So these are different categories, again mutually exclusive, no overlapping, and there's no order to it. Unless in your study you're looking at a well which is contaminated and how far are they from each well, then from say a cholera epidemic kind of a thing, so then there can be an order to it, but otherwise this is without an order. Grade of fatty liver, there's an increasing order, A, B, C, D, or 1, 2, 3, 4, or grade of murmur, whatever it is, there's a grade to it. So that is when you say ordinal. Continuous, height, weight, BMI. Okay, so this is a number. And discrete is number of patients with high triglycerides. So you can't have 11 and a half patients with triglycerides increased. So it is a definitive complete number. So that's a discrete variable. So again, obese, non-obese is a binary variable. More than 2, that is city of residence, becomes a categorical variable with more than 2 categories. And grade of fatty liver becomes an ordinal variable because there is an order to it. And numerical can be continuous or discrete. So how many groups? Now in this, how many groups? Yes, anybody from the audience, how many groups are there? Dr. Abhilash, how many groups are there? Louder? 3 groups, okay? So here in 3 groups we are going to study. And so if it is 3 groups, obese, overweight, and normal, 3 groups. You can club the obese and overweight into one group and that becomes 2 groups. Within one group, I want to study triglyceride versus cholesterol. That was one of our objectives. So it becomes a one group thing. So this is our third question that we have answered. First, we have answered what is the variable? Is it normally distributed? And what are the groups? So what is the data size? Data size, the rough rule of the thumb is quite often you will see many studies which have minimum 30 patients. So where does this 30 come from? So usually more than 100 in the sample size usually results in more robust data. They usually tend to be normally distributed for physiological variables, and that is the Z-score. The Z-score is what we use for analysis in them. The common studies which we do as a part of thesis and simple studies have 30 to 100 patients. You have to check whether it's normally distributed or not, and we use T statistics if it is normally distributed, or you use the U, that is Mann-Whitney U statistics, if we are having less than 30 samples. So in a small sample size, even if it is normally distributed and it is less than 30, it is better to use non-parametric statistics. Okay, so you use non-parametric statistics when your data is skewed or your sample size is less than 30. So this is the second rule of the thumb. So then, is the data normally distributed or not? How do we usually say it's normally distributed? We just draw a histogram. If you get a bell-shaped curve, we use a PP or a QQ plot. If all the dots are more or less on the line, then we know it is normally distributed. We can use Kolmogorov-Smirnov test and Shapiro-Wilco test. If they are more than 0.05, we know it is normally distributed. You use 2-3 things. You eyeball the data, you look at these things, and then take a call whether it's normally distributed or not. Why do we worry about normality? Is because you see the blue graph, which is the Z distribution. This is what we use for bone mineral density and all that in a large population, large studies. But T distribution tends to become closer to the Z distribution when the sample size goes more than 30. So less than 30, the T distribution you can see is totally flat. This is a flat one. So you cannot use the assumptions which we use for the Z. So ideally, it is the large, robust data with the Z distribution is what we need. But quite often, we can't achieve those sample sizes, so we use a T distribution. So T distribution, so minimum we need 30 to get to some level. I would say larger than that is better. So why are we so worried about this normality? Because if it is a normally distributed data, which is also called parametric, most large data physiological parameters, we represent it as mean and standard deviation. We use a bar graph with an SD bar, and we use student's t-test. Whereas if it is skewed, as well as I said, when it is a non-parametric statistics we have to use, and we represent it with median and 25th centile and the 75th centile. We use a box plot and we use a Mann-Whitney U test. Okay, so the choice of the statistical test depends on our assumptions of normality and randomness. Actually speaking, most of these statistical tests are based on a fundamental principle of randomness, random sampling. So we normally in PGI or any other institution, we can't, randomly pick up patients with SLE. So the minimum thing you can do is to consecutively pick up serially all the patients with SLE from your date of start to date of end of your thesis. So that minimum, there is a consecutiveness component to it, because we can't go to the community and pick up random. The last part is related. Are the samples related to each other? How right eye, left eye are related. Twins are related. Control 4 match to case 4 is related. And before and after in the same patient is related. So when we do such kind of analysis, these are related samples. You cannot use the assumption of independently two groups. Okay. So unrelated is triglyceride in obese group versus the triglyceride in the non-obese group chosen independently. So we have obese group, non-obese group independently chosen, and in them you're looking at triglyceride. So these are two independent groups, and we use this, in that it is not related. So which test? Categorical versus categorical. So is your exposure variable and the outcome variable, both of them are categorical? Are both of them continuous, or one is categorical and one is continuous? So simple thing, 2 by 2 table standard chi-square test. Related samples, McNamara test. 3 groups, again we use chi-square test. Okay. So let's take a simple example, obese, non-obese, high triglyceride, normal triglyceride. So what are we seeing here? 70 patients have high triglyceride, control group 10 have, and here we have, sorry, this should have been 30, and 10, and then normal group there is 30, and normal triglyceride 30 and 90. So you see the ratios are different. Can you observe that it's 70 and 30 and it's 10 and 90? So you think that obesity may be associated with high triglyceride level. So here we use a chi-square test, and let's do a chi-square test and see how it pans out. Suppose our null hypothesis is that there is no relationship between obesity and triglyceride. So what should be 100 obese patients? How many should be there in the high triglyceride, normal triglyceride, and in control? How many we should have? 50, 50, 50, 50. Okay. So 50, 50, 50. But what happens is that we actually find 55, 45, 45, 55. So this could have happened by random chance. And that random chance, p-value of 0.15, means that there's a 15% chance that this could have happened randomly. But our cutoff is 5% random chance. So this, we will reject this null hypothesis and say there's no relationship. Then it's 60, 45, 60, 40, 45, 55. Now you see what has happened? Some change in proportion, and p-value has become 0.037. So here there is a 3.7% chance that it has happened by random chance. So we now reject the null hypothesis and accept the alternate hypothesis. And we say there is an association. So this can be 60, 40, 35, 65. So you see that the control population are less likely to have high triglyceride now, and now the p-value becomes 0.0047, that is 0.47% chance that it is random distribution. So your p-value keeps on going up as it becomes less and less by random chance to have had such a kind of result which you saw. So we are observing more in this group than what we expected. We got 70 instead of 50 and 90 instead of 50. So this observing more than expected is a chi-square test is what we are doing, and we see that there is an association, but we cannot say it's causation, for which we have to have Bradford-Hill criteria. So this is how we represent this thing, and we report it as obese group more often have high triglycerides than the control group. 70%, you actually put the number 70 by 100, and you put the numbers versus, and you put your p-value, because you need to know what was your n on which you worked. Okay. Describing binomial variables, all of you like pizzas, huh? So it is a segment of the pizza is your event of interest, that means high triglyceride, and this is normal triglyceride, the remainder of the pizza. So the event of interest is the yellow part, that is how many had high triglyceride and how many had normal triglyceride here. Okay. So binomial odds is slice of the pizza divided by the remainder of the pizza. Whereas risk is slice of the pizza divided by the whole pizza. Okay, so the denominators are different. Now, so that is why odds ratio is in the obese, slice of the pizza by the remainder divided by slice of the pizza by the remainder in the normal group. So that's the odds ratio. The risk ratio is slice of the pizza by the whole pizza divided by slice of the pizza by the whole pizza. So that is your risk ratio. Interpretation of RR, if it is 1, it means same in both the groups. If it is about 2 to 5, we know it's moderate risk, more than 5, big risk. So these are all rough thumb rules. There's nothing. And usually we represent protection on the other side. 0.2 to 0.5 as moderate protection and 0 to 0.2 as good protection. So notice that between 0 and 1 is the same as the 1 to infinity. So whenever you represent on this side, it may look as if it is a very huge number, but here 0.2 is equivalent to 0.5, is equal to 5. 1 by 0.2 is 5. So how do we calculate number needed to treat and risk difference? Risk in the drug arm minus risk in the control arm. So here we had say the response in the drug arm was 80%, which means 0.8, and response in the placebo is 30%, that is 0.3. So 0.8 minus 0.3 is 0.5. So 1 by risk difference is the NNT. So this is 1 by 0.5, which is 2. That means you have to treat 2 patients to expect 1 extra response in the interventional arm compared to the control arm. Okay, so smaller the NNT, more efficacious is your intervention. So for continuous data, if you want to see association between 2 continuous variables, you use correlation. When you want to say that increasing age is associated with increasing blood pressure, it is regression. And when you want to say one value, your blood sugar value done in the lab agrees with the blood sugar done on your glucometer, it is Bland-Altman plot. Okay. So here we say that increasing weight and increasing cholesterol, you want to look at the association. Both of them are normally distributed. So then we use the Pearson R. When we use, so this is the Pearson R, 0.526, that means that is the R value, and this is the P value, 0.001. You never say 0.00 because actually it will end up as less than 0.001. So it's never absolutely 0. So this is a positive, strong correlation between both of them. This is a low positive correlation. This is no correlation. And this is low negative correlation. And this is a tight, high negative correlation. Okay. So increasing weight, is it associated with increasing triglyceride? You remember triglyceride was a skewed distribution. If even one of the variables is skewed, we use non-parametric statistics. If out of the 2 variables, even one is skewed, non-parametric statistics. So you use the Spearman rho. Now, if you want to say that increasing weight is associated with increasing cholesterol levels, we use linear regression. So that is when our outcome variable is continuous and your input variable may be continuous or categorical. So increasing weight is associated with high triglyceride. Now I have made the triglyceride into a categorical variable, more than 200, less than 200. So when your outcome is categorical, it becomes logistic regression. Okay, so these are just, I'm just introducing you to the terms. Obviously, we can't go into great details. Fatty liver, one ultrasonologist does and another ultrasonologist does. One person says 70% are having fatty liver, another person says 60. So for each patient, we are going to see how they are agreeing with each other. And that is the kappa statistics. So agreement between 2 people who are categorizing patients as yes and no becomes kappa. We use kappa statistics. But if I from one lab do triglyceride and another lab also do the same triglyceride, I'm comparing 2 continuous variables across 2 labs. Then it becomes the Bland-Altman plot. So similarly, blood sugar done by glucometer and the lab, are they agreeing with each other? So that becomes Bland-Altman plot. To summarize, is increase in weight associated with increase in cholesterol? We will use Pearson R. Give me 2 minutes, please. Is increase in cholesterol associated with increase in triglyceride? Because triglyceride was a skewed distribution, we use Spearman rho. Increase in weight results in increase in triglyceride. Here we are saying one thing is causing the other. So there it becomes linear regression. And when your outcome variable is, When your outcome variable is, once again, I have to go back to the previous slide. Yeah, when the outcome variable is high or low, hypertriglyceridemia becomes a logistic regression, and one person agreeing with the other for a categorical assessment is agreement kappa statistics, and I told you about the bland altman. So coming to skewed distribution, I will need 2 minutes, please. So for skewed distribution for the same test, we have categorical versus continuous. So obese, whether there's increased triglyceride or low triglyceride. So we use the student t-test if it is between two groups, obese versus say non-obese. Paired t-test if it is before and after, you're looking at a variable like blood pressure before, blood pressure after. And ANOVA if it is across three groups. The equivalent ones for non-parametric statistics are the Mann-Whitney U-test, the Wilcoxon sign rank test, and the Kruskal-Wallis test. Okay. So we will not go into this. So just one simple thing about the independent sample t-test, we are just trying to say that the means are very different across, and so they must be coming from two different populations. So you see, if I'm looking at the cholesterol level here versus the cholesterol level here, they're so different. The bell-shaped curves are so different that most probably these are coming from two different populations, and hence the populations are different. So you see, there's some overlap, but there's most probably they come from two different groups. So one is obese and one is non-obese. And so the 5 simple steps for statistical analysis is you have to have a pre-specified analysis plan. What you're going to analyze, this is what you write in your thesis protocol. You organize your data in Excel and take it into a statistical program. You check the status of these 5 things we discussed. The group 1, 2, or 3, normally distributed or not, size less than 30 or more than 30, variable, what was it, categorical or numerical, and are they related or unrelated samples. Then you apply the tests, I've told you, and I'll give you a handout as to how you can use it, and you present your data as text and graph. Okay? So do not torture the data till it confesses, till you get a p-value of less than 0.05. So this is a common problem. So which statistical test we have already discussed, and I'll give you, we have done the ground rules, and subgroup analysis should not be done unless it's pre-specified, otherwise it increases too much of alpha error. Thank you. Okay, so I'll now invite Professor Rakesh Agrawal to speak to us on how to write a paper. And since this is a short morning breakfast session, there's a limit to how much we can go to in detail. Dr. Rakesh, please.
Thanks, Usha, and thanks those few people who decided to come for this session. The slide that was put up in the beginning that showed my affiliation as JIPMER, that has changed. So I'm at SGPGI. Let me clarify that. So in the next 20 minutes, I'm supposed to talk to you about how to write a manuscript once you have done your research. So it's a bit like how to cook a dish. You have to look at what do you want from the dish. So what do you want from a good and effective paper? What are the essential components? And I would like to emphasize 5 things. The content, and that's actually the most important. Structure, whether all parts are complete, whether it is accurate, and what is the message that comes out. Starting with the content. So once your research is done, or once you think that you want to write, first thing you need to do is very seriously think, do I really have something to convey? There are times when we have done something, and if we think about it, we need to be sure that there is something to share. Writing a paper for the sake of writing a paper is no fun. It's wasted time for yourself, for the journal editors, and also for the readers in case it is published. If you do have something to say, is it worth saying it? Is there something new? And then what is the format that it is suitable for? Is it an original paper? Is it a short paper? Is it a letter to the editor, or is it a review? If you decide that you're going to write anyway after this, then you need to think of the structure. All of us wrote essays in school, and that's what the teacher told us. You have a short beginning. Sorry, this is crazy. You have a short beginning, then you have the main body of the paper, essay, and then you have a short ending. What we do in scientific papers, I'm talking about papers based on original data, we divide it into 4 parts. A short introduction, then we have methods, results, and discussion, the so-called IMRAD format, the acronym derived from the first letters of these words for different sections. And Sir Bradford Hill, who was a statistician in the UK, said that each of these sections must answer a question. Why did you start? What did you do? What did you find? And what does it all mean? And let me take you through each of these. One must remember that size of these sections varies, but people are uniformly clear that the introduction section really needs to be very short. So if I was to divide it, I'll say it should not be more than 10% in the length of the paper. The other 3 sections could vary. Discussion could sometimes be short, sometimes be long. But the papers that need to be the most detailed, the sections that have to be most detailed are the methods and results. So the introduction section answers the question, why did you start? So you need to give some background information so that the readers have the background information based on which they can, when they read your paper, they can understand it, they can evaluate what you did, and they need not go back to the previous publications. They should just have sufficient amount available to understand this. Very often we think that it is meant to be a whole review of literature, and that goes from our thesis format. No, it must be very concise. So concise and still informative. So in a way, you start off with a paragraph on what is known, what is not, what is unknown, what is the issue that is unresolved, and why it is important. Sometimes after a global perspective, you would give a regional perspective, a local perspective, and then end up with your objectives. So this needs to be brief, clear, clearly define the nature and scope of the problem. You may provide some references for people who want more details so that they can go there. If the question arose from your own previous work, it's perfectly fine to cite your previous work. You may sometimes also say what is the study design you used. If the previous papers are observational and your study's main point was to do an interventional study, you need to say that. And as I've already said, no historical details, no detailed review. Introductions can be as short as this. You see that 2 sentences there in the beginning? Those are all, that's all the introduction of the Nobel Prize winning paper of Watson and Crick. There couldn't be a shorter introduction, and this is what brought them Nobel Prize, so you don't need to be very long. I'll skip this slide. The method slide says, what did you do? So you need to talk about what was done, how was it done, when was it done, who did it, including how the results or data were analyzed, and did you have ethical clearance to do that. Now this method section will vary with the study design. It will be very different for clinical trials and very different for surveys, animal experiments, when you evaluate a new test, and again very different from unstructured review, meta-analysis, economic analysis, etc. Each of them needs a very different description. So even within human studies, observation and interventional studies will be very different. You need to talk about whether allocation was random or non-random, whether the control group received a placebo, they received an active drug, or they received standard medical therapy. Was the assessment open or blinded? The inclusion criteria for subjects, the exclusion criteria, where did you get these subjects from, a hospital or community? What was the comparator, ethics clearance, informed consent, etc. You need to talk about how were these people followed up, how frequently, at what time points, and by what method. What were the outcomes? Primary, which is generally 1 or 2, secondary outcomes, and what were the cutoffs for each outcome. So if you say we looked at whether the blood pressure was controlled or not, you need to say what does blood pressure control mean. Statistics, Dr. Usha has talked to you about, so you need to talk about sample size calculation, for which you will need a p-value cutoff, you'll need a study power, you'll need to talk about what difference in the 2 groups you are looking at if you are comparing 2 groups. The test that you have used, this should be chosen a priori. You need to talk about the software that you used. The whole idea is that the method should be so detailed that a reader who wants to repeat the study should be able to repeat it exactly as you did it. It helps to place your methods in a chronological order, starting from the study design. How did you choose people? What was included? What was excluded? What interventions were done? What outcomes were measured? And what statistical test was applied? And it is helpful if you place subheadings, and it helps the readers. Everything in paper writing is about thinking how can you make the life easier for the reader. You can use figures, so you can talk about how you enrolled people and how they went into different procedures, and you can also talk about the lab procedure, and you could draw a diagram. That makes it simpler, is easier to understand, and fewer words. Results, again, it will vary with the study design. And now here also you can make subheadings, but now you try to make sure that the subheadings you used in methods. So if you said there clinical evaluation, radiological evaluation, lab tests, histological evaluation, you should have the same subheadings here in the results. So these, as I've said, they'll vary. So before you start writing the results, you should collate all the data, make a master chart, list all the variables that you have in the method section. So list all of them as each column heading, place data for every subject under that, make sure that there are no missing data, and then think, do you have some other data which were not finding mention in the methods? If not, if you're going to include them, then you need to add that to the method section. Prepare your master tables, look for interrelationships between one variable and the other, and then you can plan how are you going to present your results. There will be a lot of information. You need to think what I'm going to include in the paper, what I'm not going to include. The main thing about results is the results are of three types. You could present the data in text, you could present it in tables, or you could present it in figures. In written papers, tables are better than figures. For oral presentations, figures are better. Figures, even in printed paper, are very good if you want to talk about time trend. So generally, you would present the results in the same order in which you listed the methods chronologically, but sometimes in some papers it may be useful if you give the positive result first and then the negative results. Avoid statements whose meaning is not clear. Always provide actual numbers, not just the percent values. Don't emphasize percent values if your number of subjects is small, especially if it is below 100. And don't go on to I had 4 patients out of 7 who had something, so I talk about 57.1247. No, just talk about what you can reasonably say. If you made multiple groups in methods, each of those must be followed up in the results. So statistics we have already heard about. There are some terms that we use in statistics. These must be used very carefully for their statistical meaning, not in their meaning in the lay language. So when we talk about correlation, that can only be between two continuous variables. When we talk about random, it's not that out of 50 people I gave something to 30 people. I did not follow a random number table or such procedure, then in that case it is haphazard, it is not random. So you need to be very careful with these words. You can use tables, but every table must be complete. Every column must have a heading. Every row should have a heading. There should be a stub. Table must have a title. Table may have footnotes. Figures, you need to be careful. Your pie diagrams actually should not be used much, but when you use, please don't use 3D. Use 2D. In 3D, because of this, the pies that appear closer to you appear disproportionately larger. In bar diagrams, this is too complex. You do not know where to read this value. Should I read here? Should I read this one? So if you do that, they should be simpler. This is, as the one on the right is actually more accurate and much less ink is used. The principle that I teach my residents is no wasted ink. Your printer should use the minimum amount of ink, and then the figure would be the best. If you have long labels, you can use horizontal bars. If you want to show two different things, compare two groups, you can use more complex bars. Where you want to show components of the whole, you have other type of bars. Then there are histograms. If you have a gel picture or lab experiments, everything must be labeled very clearly. Font size should be uniform. You can use arrows. When you use arrows, arrows don't need to go in different directions. They all run horizontally or vertically. Label the lanes. When you want to show changes over time, whether it is some lab parameter changing or survival, then you can use figures. They are very good for this. There can be more complex figures, and I'm not going to, because of lack of time. So this figure actually tells you the GDP of a country, the survival of children up to the age of 5 years. The circle shows the size of the birth cohort of the country. The color shows which continent they are located in. So you can have figures which can show multiple things at the same time. Discussion, you start in the first paragraph by summarizing your major findings. Then you discuss the strengths and limitations of your study. You talk about how these findings fit into what is already known, the major findings, and then you talk about the minor findings. And finally, you conclude what do these imply for patient care, for future research, or for economic purposes, and then you finally end with conclusions. Very often, discussion sections start with history. Hepatitis B was, prevalent 3,000 years ago because we can detect it in the Egyptian mummies. Sorry, or it was discovered by Bloomberg. No, we don't need to talk about it. You start with your major findings and not all the results. Don't use the best data. The first study, superlatives are not really good to use. Finally, you come to your message, the third part. So now your message, your conclusions should match with what your original study question was. It's not unusual to have a study question is very different and the conclusion is something very different. Your conclusion must be based on what you found in this paper, not on what other studies have shown. So because you did this study and this should answer that question. Finally, does it matter? If you found this, so what? Does anybody even care for that? And that's what you need to talk about. You need to talk about only those findings that are supported by your data, and you end with a take-home message. Finally, we are using language. The language must be precise. Precise means what you write should have one and only one meaning. People should not be able to misinterpret it. It should be familiar words. We did this instead of saying we accomplished this. You don't have to use flowery words. Flowery words are okay for your English teacher when you write English essays. Scientific papers have to have simple language, concise, make it shorter. A smooth and logical flow of thoughts is important. Finally, this is not complete. You need to add other sections. You need to have a title, authors, abstract, keywords. Time doesn't permit me to go into that. An abstract is a succinct, accurate summary of the paper, and this will be in Medline. Journals have different length restrictions, 150 words or 250 words. Some journals want a structured abstract, so you need to think of that. These cannot have abbreviations, references, and you should include actual data. The numbers and p-values must be included in the abstract, and there cannot be anything in the abstract that is not in the main paper. Finally, you need to be sure whether everything is accurate, and I'm not going to spend time on that because of the total time allotted. Is this done? No. Once your first draft is ready, you need to rework on this multiple times. And you see something on the right? And this will happen multiple times. Without that, the paper is not done. Then give it to a colleague to read, and this colleague has to be somebody who can be critical and whose criticism you are willing to accept. And you get the feedback from your worst enemy and you rework on it. And I've already talked about language. Once your paper is ready, then you need to, ideally you should have thought of this earlier at the beginning, which journal are you going to submit. And the problem today, one of the major problems today is a lot of predatory journals. And you really need to think, I'll just leave it, this phrase with you, think, check, submit. There is a website by this name, Think, Check, Submit. Go to it, and that should give you some tips about how to avoid submitting to a predatory journal. Thank you. If there are any questions, I'll take those up.
Rakesh, can you please join us here? We have had all the 4 talks, and we structured it in this way so that we can have all the questions related to these 4 talks at the end. So right now we would like to invite you to ask your questions. It may be related to your thesis, it may be related to the work that you're doing or a study which you presented in your journal club, whatever it may be. We would like you to interact with us. We have some time now for that.
They don't want to trouble us. That's fine. Yeah.
Well, while we are having some questions, so it was clearly, outlined the whole process of manuscript writing, and so most of you must have written your thesis, right, or must be doing some thesis. You must have come across several difficulties. So you may share, and we can answer those questions as well. Any of you, please come to the mic and just have discussion.
Shout. We can hear you. There are not so many
Okay.
people.
So this was a wonderful workshop. I want to ask, if you do not have a reference sample size because of, some studies not available, then how do you calculate a sample size for a research question? I mean to say that you have a research question, but the same work is not available, and you really do not have any reference to say what should be the difference between the two groups, logical difference. And how should we start? We should be starting it with a non-inferiority trial, equivalence, or superiority. So,
Yeah, I would like to add, maybe Rakesh can add after that. What I would like to say is, first of all, when we say there is no research in that area, be very careful before you make that statement, because there may be something which you have to go into deeper analysis of the existing literature. The second is, what is the effect size? Suppose you think that the baseline response in, say, the placebo group is 30%, means without any treatment it is 30%. Then in this group, how much are you expecting? A 30% difference, a 40% difference? How much is the difference which a clinician would think is reasonable to make a change in his prescribing principles, whichever he has? So that is your effect size. For a 30% increase in the response, are you ready to prescribe a new drug which has come into the market? So that is the effect size. So sometimes it can be an assumption as to how much is your effect size, but your baseline proportion, again, you can see various studies, you may get a hint where is your baseline. If you don't have, then it becomes a pilot kind of a study where you assume a lot of these things. Dr. Rakesh, you want to add something?
So let me give you an example. Let us say you somehow notice that patients with ulcerative colitis who are given metoclopramide seem to improve, right? And my question is, can I use this treatment to add to the existing treatment? The existing treatment's response rate is 70%. If I were to tell you that you could add this and improve the response rate, would you like to use it if this response rate improves from 70 to 90%? Yes or no? Anyone?
yes,
Yes. If it increased from 70 to 85%?
maybe we should think.
70 to
actually.
80?
I think we should.
70 to 75?
No.
Right. So I kind of see that people are okay up to 70 to 80. Some people are okay up to 70 to 85. Now that is the difference that we think that a reasonable clinician thinks, and that is what you would calculate your sample size on. Now let me give you another example, and it was that if you give people 5 leaves of tulsi to eat in the morning, and that would improve it. Now if it increased from 70 to 90, would you do it? You will. 70 to 85, 70 to 80. Okay. Now you may be okay even with a smaller difference, because you know that this is something cheaper, non-toxic. On the other hand, if I had said thalidomide does it, I'm sure you would be very careful when I said 70 to 85. So you can, as a reasonable physician, what we do every day in the OPD, that's how it is. I hope I answered your question.
Yes, any other
Another
questions?
question? Go ahead.
We have another 10 minutes for discussion, so take.
Good morning, everyone, for this nice presentation. So I have two questions. So if I'm performing a study on a comparably rare disease, and we are having maybe a pilot design having maybe 40-50 samples. So how to justify that I'm performing a pilot design in such a condition, number one. And number two, being a very small sample size, I may not get the significant result that I'm expecting in the two groups, but I might get a trend that probably one group is slightly better, but it is not statistically significant. So in writing a manuscript, should I address this in my conclusion or my in the results section that it is showing a trend? It might be superior to other group, or I just say it's still not statistically significant.
I think it is an underpowered study. It's a pilot study. It's an underpowered study. So if you want to share your results with the world, you should be transparent about it. You say because of feasibility issues, we could recruit 40 patients, 50 patients, and this is what we found. This is underpowered, and this is a trend which we did find, but whether it would actually turn out to be actually superior or inferior, we cannot comment.
Okay, let me give you an example. I have a 5 rupee coin, right? So, and Vishal gets a new, there are some 20 rupee coins now, right? He has a 20 rupee coin. If I toss this 5 rupee coin 10 times and I get 4 heads, okay? And Vishal tosses the 20 rupee coin and he gets out of 10, 7 heads, right? Statistically, it is not different. Are you okay in saying that there is a trend towards greater frequency of heads with 20 rupee coin? Are you comfortable with that? Have I answered your question? No, this thing can happen just by chance. Okay, and actually more often than 5%. We still allow 5%. So I don't think you should say that there is a trend. What does the trend mean? It just has happened by chance, right? It could as well have happened on the other side. The problem is when the trend is in our favor of what we are thinking, we say there is a trend. When it is in the opposite direction, we don't talk about it. So I don't think that we should even talk about at all about trends. You decided beforehand. I can be Abhinav Bindra. Take a gun, shoot it on the wall 3 times. After you've got the thing, draw the circles. 10 out of 10. Right? But that's not Abhinav Bindra.
That's why with that chi-square example I showed how 100 patients in both the arms, 50-50, 50-50 is what you should expect with null hypothesis. So if you get 45-65 and 65-45, those little differences will start happening by random chance. The number of people wearing blue shirts versus say black shirts here is just a random chance. Maybe on a day where there's a breast cancer prevention day, maybe more people would be wearing pink shirts or pink clothes. So it is beyond a random chance. So what I'm trying to say is just a little variations that we pick up in small sample size quite often will be erroneous. So we should not overinterpret that. We just understand that it is underpowered, it is a pilot, and whatever you have got, you express it in your manuscript.
Actually, let me go a step further. There is no justification for doing pilot studies unless you are actually doing it as a pilot to be followed by a larger study. Pilot studies, in my understanding, pilot trials, in my understanding, are unethical. You are putting somebody at risk without the advantage of answering the question reliably. So I don't know why if people have to do thesis is not supposed to be research. Thesis is supposed to be teaching people how to do research, how to collect data, etc. Why do people do trials as a part of thesis? I don't understand. They should just do observational studies if they cannot reliably answer the question, if they cannot get the adequate sample size.
Thank you.
So usually institutional theses are a way to first learn how to do research. Only when you do, you realize what are the problems in recruiting, what are the problems in analysis, what are the problems in writing a paper. So the more important thing is to understand how research is being done. So that is why choice of your topic is also very important, and you have to see what is the feasibility issues within the time period that you have to do.
Just one
Yes.
comment I would like to make here, and this I've said again and again, that sample size calculation is one of the biggest problems with the current research methodology, because it is more often abused rather than really put to a proper use. So you will see papers being published in big journals where they will use an outcome which reduces the sample size. So, for example, you will typically see it in endoscopy papers that they will start talking about number of re-interventions as the primary outcome, because you know that if you start taking mean as one of the outcome measures, you get a very like 20 in each group. So this is actually being abused, and our insistence on a sample size calculation is actually being abused in designing studies and reporting studies, and using outcomes which may not be as important.
So we at 9:05, we have the next session. So we have to wind up this. Any last question we'll take and we'll close.
Ma'am, I have one question for you, ma'am. Uh, Actually, when we present data in a tabular format as well as in a graphical format, we are using mean plus or minus standard deviation or standard errors of mean. But most of the time it is used interchangeably, that is standard deviation or standard error mean. Which one we have to use and why we have to use? Does it have any population, and where we have to use? Standard deviation and standard errors of mean.
Yeah, both of them represent completely different entities. Mean and standard error of mean is that what is the actual standard error, that depends upon your sample size. So it is by a formula in which your n is in the denominator. So the larger the n, your standard error of mean will be smaller, and the standard deviation is for the distribution. So how far is your patient lying from the mean of the distribution? So that is the standard deviation. So when you want to describe a population, you want to use standard deviation. So that is when we use standard deviation. So that comes with you will describe it with a bar graph, and quite often that comes in the text or the table. Whereas the standard error of mean is when you extrapolate this mean into the whole population, the big N that we were talking about. So that is the standard error. So that is a different entity, and standard deviation is different. Both of them are talking of two different aspects of it.
Okay, thank you.
Really speaking, in a paper, you never mention standard error of mean. You only mention standard deviation where it is needed. Standard error of mean gets used in calculating confidence intervals, but you don't mention standard error of mean ever. Some biology papers use it, but those are when they use the same strain of mouse which is genetically homogeneous, or the same cells which are divided into 3 plates and use. That's a different situation. For human studies, we'll never use standard error.
Thank you. And I think we'll close the session now.
Sir, we'll request you for a group photograph.